title and who you're affiliated with. Make sure they know you're a student and it's okay to proceed with the exam. We'll be doing a head, eyes, ears, nose, and throat exam today. Is that okay with you?
It's okay.
And once we get that consent, we'll make sure that before that, obviously, we should have got the demographics, patient demographics. I know who Nolan is, but get patient demographics. Nolan McCourt, right?
Yep.
And his date of birth.
1696.
And make sure the lighting in the room is okay. Make sure you demonstrate professionalism throughout, and then we'll go from there. So I will need an otoscope and an ophthalmoscope, so Seth's going to get that for me. I'm going to get which these are out in the room already for you guys, a tongue blade, which I am a big advocate of. Hint, hint, hint. If you go through my group, you better use it very good. Better use it through any group, but especially my group, because these are underutilized in the clinic. Other than the back of the throat for sore throat issues. So when the patient comes in, we'll let you go ahead and start. Austin, I think that I'm going to inspect the eyes, or excuse me, inspect the head to start out with.
Inspect head and face for symmetry, contour, and deformity.
So here again, Noah looking straight ahead at me, looking at contour, looking at symmetry, looking for any type of deformities. Noticing his face sees, he's alert, he's giving me good eye contact right now. His head looks symmetrical, I don't see anything concerning just from an inspection. Then I'm going to palpate his head, correct, Austin?
Correct. Inspects hair and abnormalities and palpates hair for texture and distribution.
Okay. So when we look at his head, we want to start to look at the distribution of his hair. Good thing with Nolan, his hair is really easy to get through and check for infestation, dandruff, any type of abnormalities. Notice that he has kind of a coarse texture to his hair. I would argue probably that if it grows out, it has a little bit of curl to it.
It's very true.
Yep. So you can look at volume, texture, things like that. But just looking, I don't see anything that would be concerning, okay? You measure your classmate's hair up all you want to. But do inspect the scalp, looking at not only the hair, but the scalp as well, making sure to see types of scrapes, abnormalities, infestations, I said before, types of infections. Some people get atopic dermatitis in their hair. And so just be careful to look for that.
Palpate head and face for masses and tenderness.
So we'll do head and face. So I usually start with the head. So the biggest thing here is just that you get kind of a global effect and making sure that you don't feel any type of abnormalities. Okay. If it was a kid, obviously I'd do anterior fontanelle and posterior fontanelle if they were young. Then face, kind of doing the forehead. Kind of coming around, as I said, kind of just kind of an overall general exam. Okay, so everything feels normal there.
Palpate TMJ movement, open, close, lateral, left and right.
2 fingers, so he's going to close his mouth to start with. You'll be able to feel an indentation. Notice how I'm in line with ear landmarks here, okay? So what you want to do is make sure you're kind of in this little indentation. Ask him to open up and down about 3 times. Down. So you're looking for subluxation thing. It has a little bit of crepitus. You can hear it. And then ask him to go right or left if they can do it. Okay, good. And just looking for tenderness, listening for crepitus, making sure that's not overly painful. But he does have a little crepitus, so you can feel that.
Now onto the eye. Assess visual acuity, verbalizing one eye at a time and then both eyes.
So ask him if he's wearing any type of corrected vision. No. And just know, guys, I did incorporate the eye that we did last week into this one. It's the same exact thing. It's just one big checklist. I introduced the eye last week, so we'd have more time to do head, ears, nose, and throat this week, and neck, okay? So just make sure you understand that. And so visual acuity, 14 inches away, 6 foot away, or 20 foot away, just depending which chart you're using. And so I would have him cover one eye. I'd hold the chart at the appropriate length, ask him to read right to left, get a reading, look at it, switch eyes, read this chart again from the opposite direction. So if I read right to left, I now do left to right, get a reading, and then I would do voice, then I would do both eyes. All you have to do is add voice, that I do both eyes, and I do with and without corrective lenses if he were wearing them, okay?
Inspects the eyebrow and eyelids, noting symmetry, erythema, or lesions.
So look at his eyebrows, they're continuous, don't see any types of infestation, they're consistent across, don't see any thinning. Look at his eyelids, look at his lower eyelids, look at his top eyelids. Can you close your eyelids for me? okay? And then as he opens his eyes, and make sure he has no signs of ptosis or anything like that. Before I start palpating anything, I want to make sure I have gloves on so I don't infiltrate his eyes with anything foreign. Next.
Inspects and palpates the lacrimal apparatus.
So lacrimal apparatus is here, and then the actual lacrimal tear duct is here. So make sure it's not swollen, it's not tender, erythematous, or any type of change in temperature to the skin.
Inspects the conjunctiva, noting injection or lesions.
Okay, I'm gonna do the sclera as well. So I would actually just look, and then I would pull down, looking at, hold your head down a little bit, look at the bulbar, that, I don't expect you to look at the top bulbar right now, we don't need to do that. Look right, look left, look up. Let go, and then look down, look right, look left. Okay, good. It might be a little bit uncomfortable for him, but checking the eyes, okay? So looking at sclera conjunctiva, sclera white, conjunctiva clear.
Inspects the pupils, noting size and symmetry.
So look at the pupils. Looking at him just right now, they're pretty constricted as they should be because of a well-lit room. They're similar in size. I don't see any type of distortion. They're round. They're both equal, and so that looks reassuring.
Uses oblique lighting to inspect the cornea.
So get to the side of the patient, ask them to look ahead. Let's get really close and look at the contour of the actual cornea. Same way here, kind of a side approach. Make sure there's no concavity or inundations in the actual cornea.
Test direct and consensual light reaction.
Okay, so here, ask the patient to look straight ahead at my nose. Just keep your eyes focused there. Swing in, this light should make this constrict some, even though they're already slightly constricted, it does. This time I'm focusing on this eye, but innervating this eye, which should then innervate back out this eye. I switch sides, look at this eye, come out. Now look at the other eye, come out, okay? Remember, cranial nerves 2 and 3 are activating that.
Test accommodation by pupillary constriction upon convergence. Cranial nerve 3.
So I'm gonna do extraocular motions and then do the accommodation. So here's how I do mine in clinic to save me time. Follow my finger where it goes, looking for the cranial nerves 2, 3, and 6. And making sure the extraocular motion is intact. I follow my finger all the way in. Pupil should constrict. I watch it very close as I come back out and see them dilate back out. Okay?
Test visual fields by compensation. Cranial nerve 2.
So just remember to be really close here. Just want to go in, cover your right eye. It doesn't really matter which side of your eye you start with. You just need to be on the same eye as him as far as over with him. So if he's starting left, I'm going to start with my right because that's one closest to him. And so I get to a level with him. Hand up in the air. Can you see my hand?
No.
I try to come straight down in the midline. You can see it. Okay. And then I come down to this quadrant. Look straight ahead. Tell me when you can see it. You can see it. Now I'll switch my hand, and then look straight ahead. And as I come across the field, this one may take a little bit longer. Okay, that's where I saw it. And then come across from the bottom. Okay, and just making sure that's the same with me. 4 quadrants for each eye, and then switch eyes. Okay.
Performs cover, uncover tests.
So cover test would be I get my visual acuity card or whatever I have, get really close, kind of block this eye off, come back, see for the correction. Same way here, move it and look for correction. If I
Then
was-
on to the fundoscopic exam.
So fundoscopic exam, we dim both lights, turn this thing on, get my focus. Since we're looking at the back of the eye, we're looking for far away. So I would, you guys can go ahead and cut the light off. And that one. And so I would try to focus on this. Oh my Lord, my vision. So that's 0. And so now I'm going to go till I can see clearly. Okay, so that's pretty clear right there. Alright, so what I'm going to do is I'm going to demonstrate his left eye to my left eye. So we want to be at a 15-degree angle. We want to tell him to look straight ahead at that door hinge. Don't take your eye off of it, stay focused on that the whole time, okay? see on his eye. Come in about 18 inches away. Red reflexes picked up. Come all the way in. Notice how I'm standing on his iris and pupil all the whole time. Come in close to where I can see it. Look all the way around in all 4 quadrants. Look into the light. And then pull back. Okay? So that's the fundoscopic exam. Make sure opposite, remember, left eye, right eye, right eye. Otherwise, you're going to be lining up being too close to your patient for comfort, okay?
Now onto the ear, inspects the auricle for deformities, discharge lesions.
So the biggest thing here is making sure you do a good exam, since most people are here. So you want to look at the ear, have the patient look straight ahead. Notice he has a little, probably cartilage.
I think so.
Yeah. This way he's made, it's probably on the same side as the other ear, not as prominent. Yeah, cool. So, just a little anomaly there, nothing to be concerned about, but what you want to do is inspect and look, fold the ear back and really inspect and look behind the ear. A lot of people get atopic dermatitis or eczema in this area here where this crease is, okay? And so you really want to look really good, okay? So after you've inspected both ears,
Palpates the auricle, tragus, and behind the ear for tenderness.
so then you want to palpate both ears. Making sure there's no tenderness anywhere, okay? Okay. All right,
Now the otoscopic uses appropriate size spectral patient.
so you want to use the big one, which is a 4.2, 2.74 for pediatrics. So the biggest thing here, guys, is when you look, this hand should be here to resist the patient's head. And so you're going to be strong on this with one hand, not strong on the other until you get practice. The ear should be pulled up and back. For kids, it's down and out. For adults, it's up and out. So notice as I go in, I'm starting to look at the canal. As I come in, I don't want to go in really yet now. I see a little bit of piece of wax there laying in his external auditory canal. It's kind of golden color. As I turn, I can angle myself because the canal does go inward, so sometimes you have to turn a little bit. But notice Nolan will never be uncomfortable during this whole exam because I'm not going deep. So I come, I look, there's his flaccida, tensa, there's a light reflex you can see at about 8 o'clock. You can see that it's translucent, it's pearly gray, umbus, malus, all those things you can see. He's got a pretty clear ear canal. No signs of otorrhea or any type of debris in there except that little bitty piece of wax. You'll see hair in people's ears. When you go to the other side, what you have to do is here again, keeping the hand up, so if he jerks, up, out, and then here again, turning. Still has a great eardrum, clear, transparent. Kind of looking around, you can see everything, and I was noticing the ear canal as I went in, okay? Make sure you don't go too deep. You don't have to be very, very much in when you put the otoscope in if you know what you're doing, okay?
Now the hearing test performs whisper hearing test bilaterally behind the patient or to the side of each ear.
Okay. So, 2 foot away, looking ahead, cover your left ear. I'm gonna say a word, you tell me know what I say.
Baseball.
Okay? Stay there. 2 words.
Popcorn.
Okay, and then I would switch and do the other ear, same way, 2 foot away. Okay, remember 2 foot away is only about that far. Okay? Other thing you can do in clinic, guys, not for your skills, but in clinic, I'll teach you another trick. It's called the finger rub test. You actually don't have to have a tissue, but if you have, or a girl, and maybe just put some lotion in your hand, or you're a guy, and just put some lotion in your hand because your hands are drying out. So can you close your eyes for me? Tell me which ear you hear something in.
My left.
What about now?
My right.
Okay, and I just want to do it a little bit more, so do it again.
Left. Oh.
Okay, so it's called a finger rub. And so it's about equivalent to the 2 foot exam, okay? So that's something else you can do for clinical knowledge, all right?
Perform a Weber and a Rinne test.
So Weber and Ryan use a 256. For the Weber, you want to hit a little bit harder. Hit on your palm. Everybody hears that, okay? So I want you to tell me if this lateralizes to the right ear or left ear, okay? Or does it stay midline?
Kind of went more to the right.
Let's do it again. Double check.
Right?
Going to the right?
Yeah.
You have any issue of hearing loss?
No.
Last time, tell me where it goes.
Right.
Okay, so we have an abnormality here. So, what you want to do is, since he says it's lateralizing to the right, you're going to check the Ryan test on this side. So you don't have to hit it as hard this time. Good. Put this on your mastoid bone. Can you feel it?
Mhm.
Tell me when it goes away.
Went away.
You still hear it?
Yeah.
Okay. So we know it's not conduction. The AC is better than BC. Okay. So, and with it lateralizing this side, if that's normal, you could have sensorineural hearing loss. So we'll to be determined. So.
No. Still
Still
hear it.
here. So, what you would think to yourself is, if Nolan's truly feeling like it lateralizes more to the right, then we check AC versus BC or BC versus AC. Had BC been louder than AC, or heard longer than AC, or AC couldn't be heard when we put it up to his ear, then we'd think of conduction hearing loss, okay? But it lateralizes to this ear, and AC and BC are normal, so what you think is sensorineural hearing loss in this ear possibly. Have you ever had any noise damage in listening to loud music?
Well, yeah, probably.
So, but the other thing you do is try a couple other parts of the top of its head and say, does that still lateralize to the right?
It's definitely right, yeah.
Yeah. So you can have some sensorineural hearing loss.
100%.
So,
Sad.
alright, so, what's in your bill?
Yeah.
Then you get your referral. Next.
Nose inspects and palpate for nasal tenderness, deformities, lesions, patency of nares.
Using all sets of equipment here, he's like, hey man, I gotta pay for those.
No.
Sanitizer to the rescue. Took a little sanitizer with me so we don't take all sets of equipment. There's you said. Is that okay with the patient? Yeah, well, I put
Okay.
sanitizer on it. And you make it a high coat.
That's what I was thinking. It's fine.
And this smells like an alcoholic drink. If you don't think I'm kidding, you come over here and get some later. And it smells almost like a sweet and sour or something. I don't know. Not sweet and sour, sweet and sour. That's Chinese food. A whiskey sour, amaretto sour. Yeah, that's what it smells like. But anyway. All right. So here is the first thing you want to do before you get ahead of yourself is make sure that you inspect the nose. Okay, so I'm looking first. He does have a bony prominence here, but that's probably again the way it's made. And just palpate once you've looked at it, okay? And make sure there are no tenderness or any deformities that you see. Then you want to ask him to cover one nostril and breathe out slowly to where I can hear it. So it's patent, okay? Not patent. Patent's what you put on something when you discover something, okay, or you invent something. Patent, okay, it means open. Other nostril, breathe out. So that's patent as well. And so now I can do my exam. So you can have him make a pig nose, or you can make a pig nose yourself, okay? So I prefer to make the pig nose, and the reason being is because I can control where I need to move my speculum, okay? So just lean back, this won't hurt. Everybody watch how I do this at the base of his nose. So first, I look and put it at the base of his nose and look around. As I go in, I'm putting slight downward pressure on his nose so this holds in place so I don't job him when I go to look at it with my eyes. Notice how the otoscope does not move. And I'm looking in his nostrils, okay? So I switch, just let you guys see. Look, you can see inside his nose, looking for inflammation, lesions, any type of rhinorrhea. So then, with it being laid there, it's not gonna move. I hold it still, come in, and try to look up. And you have to kind of tell the patient sometimes, don't breathe if you can't hold your breath for a minute. Why? Because it'll fog it up, exactly. It'll fog up this otoscope, all right? So, next.
onto the sinus, inspects the frontal and maxillary sinus area for swelling.
So maxillary and frontal sinus for swelling, so here again, underneath, kind of push up, cheeks, push up. You can feel the bony prominences here, push up. When I percuss, it's going to have to be kind of a little higher. Here. Okay, and you're looking for tenderness. Typically in clinical knowledge, if they're not tender to palpation, you're not going to need to percuss. Okay?
Onto the oral cavity, inspects lips for symmetry, color, lesions, and edema.
All right, so oral cavity. Here's your friend. Light. This one. Or this one. Tom's being strange with this other one. So, guys, big here. Big here. Cross-contamination. Don't cross-contaminate, okay? Was that Tom? Oh, it's Jeff. Do I have two over here? I didn't have two. Okay. This is Tom. This is Jill. So don't cross-contaminate. So, watch how I do this particular exam. I'm going to keep a good hand, a clean hand, and I'm going to keep a hand that actually is no longer clean, if you will, that touches him. Okay? So I get my this. Go ahead and open it. The bed is relatively clean. The sheet is. Nobody's been here. This glove's clean as well, so I feel comfortable touching that. And so I'm going to get a, use my left hand before I touch anything. Use my right hand. So. I'm not used to using this pen, which is no excuse, because it looks like a pen. I'm gonna so, open this up. Okay, this is gonna be clean. Okay, this is gonna be my dirty hand. Clean hand, dirty hand, okay? So, first of all, what we're gonna do is, we don't need this to start out with, so we can lay it on the bed, it should be clean. And so we're gonna inspect. First of all, looking for oral commissures, looking at the angles of his mouth, looking for any type of chapping, any type of swelling, erythema, lesions, any type of moles, nevi, whatever the case may be, okay? Once I've inspected the lips, I'm gonna palpate the lips. So, I'm gonna open up slightly. You just want to palpate along the lips to make sure you don't feel any swelling, any tenderness, anything like that. All right, go ahead, Austin.
Inspects gingiva for color, inflammation, and lesions.
So remember, this hand is the one I'm touching with. So, light, always. Hit down. So I want to use this as my friend. The tongue blade is doing all the work here. Okay, I'm making it do all my work to spread the gums. Okay, and then I can use it. Hold your head down a little bit. Good. So I can push his tongue back, look at the inner gingiva, and then at the upper gingiva, spreading, just being careful as you go toward the front. And as I come across, I can be really careful and just kind of lift, looking, okay? So I inspected the gingiva, okay?
Palpates gingiva for 10
Put
minutes.
this down on a clean area. This is the bed. So, open. So now what I'm going to do is just run my finger